Mission Health. Be well, get well, stay well.
Good evening. Thank you for joining us for this discussion where we'll be answering your questions about Mission Health and HCA Healthcare. I'm Karen Vernon, and tonight we're very pleased to have some special guests with us, Dr. John Ball, who's the chairman of the Mission Health Board of Directors, along with Dr. John Garrett, who's the vice chair of the board, and of course Dr. Ron Paulus, who is Mission Health's president and CEO. So welcome, gentlemen.
Good to be here.
Dr. Paulus, I know that our audience already knows you from some of our prior events, but Drs. Ball and Garrett, I wonder if we could take just a few minutes to have each of you introduce yourselves to the audience and let them know how you came to be a part of the Mission Health Board and the Mission community. So Dr. Ball?
Well, I was very lucky to become part of the Mission Health Board. This board has always been full of community people. Dr. Paulus, Ron, after he came here for several years, wanted to see if he could bring a national perspective onto the board. I sort of fit the bill because I'd retired here, but I'd also been the executive of a couple of national medical organizations and president of a hospital in Philadelphia. So it helped that I brought some kind of expertise to the board, but at the same time I was a member of the community.
Great. And Dr. Garrett?
Sure. As a practicing gastroenterologist here since about 1990, I felt that I've, for a pretty long time, had a good sense for the things we've done well in our community and the things in medicine we've done perhaps not so well. I've also worked in our outlying regions in both McDowell and in Spruce Pine almost weekly for quite some time, and because of that had become first involved in practice management, and then about 8 years ago with hospital board committee work. I subsequently came on to the hospital board, now serve as vice chair, and have been tremendously interested in national trends, especially our work in quality and data analytics.
Okay, great, thank you. So leading up to this event, we've heard lots of common questions that we're going to do our very best to address here, and we had many of those questions that were actually submitted online prior to the event. And meanwhile, for those of you who are viewing with us this evening, we certainly invite you to continue to submit those questions. We're going to do our very best to get to them, as well as answer those common questions that we've heard over the last several weeks. We'll have a designated question and answer period at the end of our discussion, so anything we don't cover at this point, we'll do our very best to get to there. So Dr. Paulus, just let's get right to, I think, the big first question that I know people have been asking since we made this announcement on March 21st about Mission's plans to join with HCA Healthcare. Tell us what exactly that means and what's happening right now.
Yeah, so thanks, Karen. It's great to be here again. I appreciate both of you being here with me. We are in the process referred to as due diligence. That's where both HCA Healthcare is taking a deep dive looking at Mission, and we're doing the reverse in terms of looking at HCA Healthcare. In fact, we had a number of visitors from HCA here yesterday and spent time with our physicians and others. That due diligence process is estimated to be 90 to 120 days long. So under the best of circumstances, that would end in early July, maybe trickle over into the beginning of August. And in parallel, we're taking the letter of intent where the board negotiated a lot of very important terms about what the relationship would look like, but that was like a 6-page document with some appendices, and we're in parallel to due diligence negotiating a definitive agreement. That will be a much bigger agreement, and so we anticipate sometime in the summer to complete due diligence, and if things go well with that, to reach a definitive agreement. That will trigger off a 90-day regulatory review process driven largely by the state attorney general. The attorney general will be looking at 3 different things. Number one, market antitrust. We don't anticipate an issue with that because there's no market consolidation going on, just a flip in ownership. Number 2 is the price that HCA Healthcare is paying for Mission a fair price? Since Mission is really a community asset and it's gotten the benefit of state and federal tax relief. And then third, and the most important question, not to diminish the other 2, is what happens to that money?
Right.
And that money will go into a new foundation for the benefit of the community, and so the Attorney General will be looking at all of those things.
And so once that's all done, assuming we go through all those stages, then at some point Mission will become part of HCA Healthcare, correct?
Right, and so typically the regulatory process is plus or minus 90 days. So that would put us somewhere between, under the most optimistic scenario possible, October, and a more likely scenario, end of the calendar year. Somewhere in that zone. It could spill over into the first quarter, but that's sort of a generic answer as to where we are.
Okay, and we'll come back and talk a little bit more in detail about some of those in just a minute, but I'd like to turn to Drs. Ball and Garrett for just a moment too, and sort of back up, and if you could talk a little bit about how the board, first of all, made a decision to seek a partner and then ultimately to seek this particular partner. So which of you, who would like to start?
Certainly, Karen. The board's responsibility is to ensure that Mission, the Mission Health System, fulfill its mission, which is to improve the health of the citizens of Western North Carolina. We look at every year, are we fulfilling that mission? Can we do it better? What are the risks to the institution? And every other year, we've taken a deep dive into, would we do better with a partner? And we've always said, no, we do better independently because a partner would have to bring us something that we can't do ourselves. And until recently, we kept that as our position. We wanted to remain independent. But the headwinds of the payer mix that we have here in Western North Carolina, the difficulty with the people in Western North Carolina being sicker, poorer, and less insured, meant that we have less reimbursement than we have cost. Every year we've been taking some $60 to $70 million out over the last 5 years. That's almost $250 million in costs taken out, and still we barely make even. So the board stepped back and said, if we found a partner who could bring us something to help us on the cost side, if not on the reimbursement side, where do we go? It led us to then do a real in-depth discussion at the board of who's the best partner. First of all, shall we remain independent? We decided we can't remain independent because that would mean cutting programs, cutting people. And we didn't want to do that for the people of Western North Carolina because that wouldn't help us fulfill our mission. The second step then was, shall we partner? We shall. And who's the best partner? And then went through the process to determine who would be the best partner. And that's where we came to HCA.
And can you tell us a little bit about HCA itself? What were those things that led you to particularly choose HCA?
I'd be delighted to cover that. And basically, as we looked at the strengths and the needs of Mission Hospital, we realized that we had a tremendous array of strengths. Our people, our staff, our patients, our quality measures, our facilities, our processes are fantastic. We, as John Ball had mentioned, we had worked very hard to perform the cost-cutting measures which we refer to as mitigation. But we all recognize, as do many hospitals around the country, that these mitigation efforts are really a dead end eventually. You can only do so much of that. And eventually you begin to cut programs, and you cut the quality, and you cut the types of things that you offer. And we realize that neither the board nor our management or our staff were really interested in seeing us cut programs and become less of a system. So when we looked at the things that we could improve significantly and benefit from merging with a larger system, were things that were not involved with clinical programs. These were things that involved IT management or our computer systems. These involve supply chain and things like all our supplies and medical costs and pharmacy costs. They also include back office issues like billing and other types of back office functions that we could not scale or do in a more economic fashion, no matter how efficient we tried to be. And so it became clear to us that some of our greatest needs were answered by some of the greatest skill sets that HCA has.
And if I could just add one comment to that. I want to emphasize, and John, you pointed it out, but I want to make sure that our watchers understand. we have great people in our back office. We have fantastic people in IT. And relative to other health systems, they do a fantastic job. The issue is not that. What we don't have is the scale and the underpinnings that an HCA Healthcare has at $44 billion in annual revenue. And not only are they good at their back office functions, they're so good that they actually sell those to other companies, including other publicly traded companies like LifePoint. So I want to be very clear that it's not that we didn't have people doing the right things. It's impossible for them to do the things that they will be able to do with the additional assets that HCA Healthcare brings to bear.
And I think that's a really important point. One other point I know, at least we've heard through the announcements, is that this was a unanimous decision by our board of directors, correct?
Absolutely.
Yeah.
So the basic thing was that the board had to decide, do we over time cut programs, endanger quality, endanger safety, or do we go with a larger entity that can provide the efficiencies of scale?
Right.
And that's why we chose HCA.
Right. Thank you all for that. We do have a couple of questions from our viewers. Nancy asked specifically, and Dr. Paulus, I think this was from our earlier conversation, we mentioned that we'll be, at the end of this process, if all goes as expected, we'll be joining HCA Healthcare. The question is, how is this different from a buyout, or is it different from a buyout?
Yes, so it's a little bit of semantics.
Okay.
So we are, in effect, being acquired by HCA Healthcare, so we will become part of joining HCA Healthcare. What's really interesting, though, because HCA recognized the tremendous skill and talent of the Mission Health staff, and they made a decision that they don't normally make, which was to make Mission Health its own independent division.
Right.
That's important on a couple of different levels. Number one, typically to be a division within HCA, you have to be above $4 billion in annual revenue. We're just below 2, so we're way off the minimum size. But what they saw here was a group of talent and an opportunity to grow within the state and within the region. And so they wanted to make the investment and make us a division. How that translates into impact for people who are part of Mission Health is that normally, if you weren't a division, other significant parts of what we know as Mission Health today would go away.
Okay.
But with a division structure, there is some IT infrastructure, there is some accounting infrastructure, there is legal infrastructure, so it's kind of like the headquarters, and keeping the headquarters was an important part for our community and for our staff, but most importantly because of the opportunities it presents going forward.
Okay, great. We have another question along the lines of the purchase. Terry is asking, do you foresee HCA purchasing all Mission entities? And for example, she cites Care Partners hospice and palliative care programs, adult day, physical therapy, and so forth. That's just one example.
Yes, so the letter of intent describes HCA acquiring all of Mission Health as it exists today. As we go through due diligence and learn more, if there's any reason why something should be excluded from that, it's not ruled out. But the intent that everybody's walking into it with is that everything becomes part of HCA Healthcare.
Okay. One of the questions that we had in advance, and I wonder if one of you, Dr. Ball or Dr. Garrett, would address this, is that we have heard a lot of questions, and Marcia was someone who particularly asked this question in advance of the event, is a lot of questions about Mission moving, this move taking us from being a not-for-profit to being a for-profit. So what are some of the considerations around that change?
Well, the first consideration is, will HCA bring something to the table that will continue the quality, the safety, and the services that people here have gotten used to? That's the case, certainly. The second thing, though, that HCA brings to the table is they pay taxes. Local taxes, state taxes, federal taxes, and that will help the community and the communities in our region. And they pay property taxes. That also will help the communities in the region. But the key consideration for us will the services that people have gotten used to continue, and under HCA that's going to be the case.
And if I could add,
Yeah.
I think clinically there are some other very important points. And when people hear for a for-profit entity, they become concerned and say, well, the reason they can make a profit where Mission can't is because they have a different staffing ratio. They may have fewer nurses taking care of the same number of patients. And that is not the case at all. HCA's staffing ratios are very similar, virtually identical to what we have here at Mission. Furthermore, other concerns that people have about the size is, or for-profit entities, are, do they fundamentally do things differently? Is it tougher for poor people to get health care? Is it tougher for people to walk in the door and be seen in the emergency room? And in fact, when we've begun to look at these things, HCA's charity care policy is actually a bit more generous than Mission's, and we don't turn anyone away. So those two very large concerns, namely, do we staff differently? Would the nature of the care be different on a day-to-day basis and on the floors? Or would a patient who had limited resources be treated differently? And the answer is absolutely not.
Great, thank you. Dr. Paulus, anything to add to that?
Yeah, I would just say that I don't want to speak for everybody, but I think we all paused. We knew that that was a big shift, and we knew that people would have concerns, and we really took a very deep dive. The point I would make is that whether you're, quote, for-profit or not-for-profit is largely an issue of whether you pay taxes or not. Every health system has to make a profit, or it can't continue to fulfill its mission and to replace its capital and equipment to expand and grow programs. The behind-the-scenes question is, well, where's that money come from? How does it work? Why are they able to pay these taxes and do these things and do better? And the answer is that that's a hard bar to get over, but they get over it. Number one, they pay less for every single thing that they buy, whether it's a Band-Aid or whether it's an MRI scanner, than any other health system in America. Second, they have access to capital at lower rates than what we have access to capital, because they have both an equity market, meaning through the stock market and can get investors, as well as the bond market. So although it's a hard bar to get over, when you add up the fact that they buy everything at a lower price than we do, and they are more efficient, particularly on the back office. Again, I want to highlight that's not because our people are bad, they're really good, but because they're so large. And on average, they pick up between 1 and 2 points on revenue cycle in every acquisition. For us, that's 1 to 2% of $2 billion. That is a very large amount of money that comes from more effective collection and billing activities. And so there are many different ways that create those dollars that can both save money and pay the taxes.
Okay.
One example on how efficient they are is that they actually make money on Medicare. They make about 2 to 2.5 cents on the dollar on every Medicare patient. We lose 4 to 6 cents on every Medicare patient. The average not-for-profit hospital in the country loses 11 cents on the dollar for a Medicare patient.
Wow, those are pretty
So what Ron is talking about is
numbers.
the efficiencies, the economies of scale is what really makes their profit line.
Right. We have another question that I believe this one came in prior to the event, sort of relates to the charity care and the, taking any patient who needs care. So Teresa submitted a prior question to ask, what will happen to Mission's financial assistance program? I know that many questions may be ones we don't quite have the answers to yet, but any of you?
We do know the answer. That as John described just a moment ago, as it turns out, their charity care policy is actually slightly more generous. We both provide free care to anyone who's up to 200% of the federal poverty guidelines. We, Mission, have a sliding scale discount up to 300% of the federal poverty guidelines. They have a sliding scale discount up to 400% of the federal poverty guidelines. And in addition, in their sliding scale component, they have a cap on the out-of-pocket maximum that anyone pays. Oh. So they will be implementing their charity care policy. So in essence, our charity care will be expanded somewhat, not a dramatic amount, but somewhat. But the concern that people, and I can understand it if they're not informed, that all of a sudden charity care is going to go away. No, not only is it staying, but it's actually going to be slightly elevated.
So that's very good news.
Yeah. And there are guarantees over time that it will continue and never be less than what is the norm in the state of North Carolina.
So that's built into the letter
So
of
that's
intent.
built into the letter of intent.
Great, thank you. We'll shift gears just a little bit now, and I'm not sure which of you all may want to, Dr. Paulus, it may be you who wants to kind of delve a little more deeply into the timeline that we were talking about. You know, you talked about the fact we're in the due diligence period and then the things that come next. Is there anything in particular on any of those stages that you think would be important for our viewers to know?
You know, it's easy to get into the weeds. I'll just give you a sense of how weedy it is, right? So we've broken due diligence into 2 phases. Phase 1 really related to a series of legal agreements. We uploaded into a virtual data room 12,347 documents. HCA has a large team of people that are I thought I could be specific. And phase 2 due diligence, which we're just in the process of completing on our end, is over 25,000 additional documents.
So they'll be reviewing all these.
So they have teams of people both in Nashville, they'll eventually have some people on site locally, and all across the country that are reviewing all that. We are doing our own due diligence. The good news is that everything about HCA Healthcare is really public.
Right.
Because they have to file all these disclosure documents to the SEC and other governmental agencies, you can find out almost anything you want about HCA Healthcare just through public documents. We don't have all those public documents. We will be supplementing our review of those public documents, which we have an outside legal team and an internal review team doing, with site visits. So we'll be sending teams of people that will include board members and physicians, management members, maybe some community members, maybe even elected officials. We haven't defined all this, just as a way of sharing transparently. And they will be going to visit both a more urban environment with a very large tertiary quaternary hospital like Mission, and more rural environments like we have in Transylvania and Spruce Pine and Franklin and the Highlands Cashiers and so forth. We will also we haven't gotten to this topic, but you can't talk about this relationship with HCA Healthcare without also talking about the extraordinary, truly extraordinary foundation that will be created with the proceeds of this transaction. And so on the site visit, we will also be visiting at least one of the foundations.
Okay, so, and that will all be happening over these next several months,
yes.
Correct? Okay, wonderful. Dr. Ball or Dr. Garrett, anything
In
to
addition,
add?
people from HCA have come here and met with our physicians and clinicians.
So they've been on site here.
Yes.
Okay, excellent. Anything you'd add to that?
I think one thing, since Ron had brought up issues about the foundation, would just talk about maybe 1 or 2 exciting concepts about that. And those concepts include, currently, we think of healthcare as being primarily what we do in the hospital or what we do in the ambulatory care center. But the reality is, we all realize that too much healthcare is provided in that setting, and that in the ideal world, we'd be preventing an awful lot more than simply taking care of someone who has advanced or end-stage type diseases. And so we look at this foundation as something unique in our nation. When I speak to people across the country about the type of possibilities and opportunities we have here, they, even in generous systems, can't believe the opportunities that we have before us, the opportunities to look upstream and attack things like obesity and food insecurity and housing issues and people who can't get to work or afford their housing. And these you don't think of directly as related to healthcare, but we have the opportunity to link that and to hopefully solve many of those problems.
And so those are some of the issues that this new foundation will be able to address in a whole new way.
Absolutely.
Right. Okay.
Amazingly, only about 15 to 20% of a person's health status is dependent on health care. It's dependent on a lot of other things for the other 80 to 85%. Right. Economic status, genetics, the environment, education. Right. These are the kinds of things that the foundation can approach that HCA will provide the healthcare side with continued excellence here, and the foundation will be able to address these other issues.
Those sort of surrounding issues
Yes.
that have a big impact on people's health.
And one final comment before you go to the next
Yeah.
question. I just want to try to wrap this up because, in essence, the way that this transaction is contemplated is that with HCA's help and their acquisition of Mission Health, there will be essentially the identical health system with the same people, the same doctors, the same nurses, the same advanced practitioners, the same pretty much everything, operating the way that it always did. With additional support, the most immediate clinical change will likely be in the cancer or oncology space. Most people don't appreciate that HCA Healthcare is the leading clinical trial enrolling site. The most patients who are participating in clinical trials in more than 3/4 of all the new FDA-approved cancer drugs in the last decade. So access to those clinical trials is just one example. They also have large investments in esoteric terms for some, but the future of medicine around genomics, analyzing your DNA for treatment, and around artificial intelligence and predictive modeling. So on the one hand, you get the same health system, same people, with all these enhancements, and then on the other hand, you now have this incredibly large new foundation that will be investing, let's just say, between $50 and $100 million per year into all of these social determinants that John was describing around childhood intervention, education, obesity, drug addiction, food security, housing, transportation. We don't have the definitive answers all right now, but we've struggled to give away $1 million to $2 million a year to those kinds of programs because we have to cut $70 million a year to keep our margin where it needs to be. Now that health system will be operating on its own, and all of these funds will be able to go directly into those programs.
Those extra resources that'll come into play.
Powerful.
Right, it very much is, and I'm sure we'll have more conversation about that either through questions or just other things that we want to add in. We do have a couple of other questions that have come in. I think this goes back to the issue of the better buying power and things like that. But Tom is asking, how will a for-profit organization rein in costs? He says, yes, I understand bigger group purchasing power, but obviously they do not plan on losing money. He says, I've supported Mission Health for a long time and would hate to see it lose its identity. So who would like to take that question?
Maybe I'll start and then add in. So first, there's a misconception that because we're planning for this, that somehow we've been losing money. We haven't been losing money. In fact, we were recently named by Becker's Healthcare Review as one of the 8 sustainable systems, one of 8 sustainable systems in America, right? So we're looking out in the long run. We do have to cut $70 million a year so that we can keep making the margin that we have been. And we cut more costs than we actually make. So last year, plus or minus, we cut $70 million and we made, around 60, okay? If we didn't cut, we would start losing money. But first of all, we're not under duress. We didn't have to do anything. We could have continued on. HCA, you're right, is not going to lose money. And they're not going to lose money because number one, that purchasing power is dramatic. I'll give you an example. You might remember that we did a deal with General Electric, and it was a really big deal, and the CEO, Jeff Immelt, came here, and we have been an innovation hub for General Electric. When I first started the negotiations with John Flannery, who's the current CEO of GE, one of the things I said was, if we're going to do all this innovation, I want the best price of anyone in America. They said immediately, right there, very first meeting, no chance. You'll never have the best price, and if you have to have that, we can't continue the discussions. I said, why? They said, because HCA has the best price, and no one pays their price. And today, in our actual contract, before we ever started talking anything about HCA, our contract with GE says when we buy a CAT scanner or an MRI scanner or an ultrasound machine or a monitoring device, our price is HCA's price plus X%. That's what the contract says. And so now the X goes to 0.
It'll be HCA's price.
It will be HCA's price. In addition is the opportunity for growth. HCA is very interested in being in North Carolina, and so lots of opportunities for growth.
Great.
And I might add, I sense another part to that question, which is when we achieve scale, when we talk about agreements and things like this, somehow it implies that Mission loses its identity. And I want to very strongly state that that is not the case. HCA is great, is a fabulous, the best hospital operator, and they're extremely efficient. But this does not mean people come in and change the signs and change this or change the staff or change the face of Mission. The mission of Mission to the people of North Carolina stays the same. And the signs stay the same. The hospital stays the same. It's behind the scenes that they provide us with these economies of scales and these efficiencies. And in fact, if you look at the websites of any of their large hospitals who have been acquired or forged different types of agreements with HCA, you'll see that you have to look very hard on their websites even to see the letters HCA, because that's not the way they do business.
Okay, thank you. Let's see, I've got bunches of questions coming in, so I'm going to kind of go through and see what fits right here. Let's go back to the question or the discussion about the foundation. Risa is asking, are we guaranteed that the resources of the foundation will stay in Western North Carolina? So, Dr. Ball?
The Board of Mission at this point is looking at and developing the foundation even as we speak.
Okay.
The purpose of the foundation will be to dramatically improve the health of the people and the communities of Western North Carolina. The money stays in the region.
Okay, so that's
no question
in.
about it. And as Ron pointed out, the Attorney General will look at the monies that were accumulated by Mission, the health system, that then go into the public foundation, the private foundation, will have to go for the same mission that Mission had, which was the improvement of the health of people of North Carolina.
Which is part of the reason for that regulatory review.
Which is the reason for the main reason for the regulatory review.
Exactly.
And just to emphasize, it's the Mission Board's 100% intent that these resources stay within Western North Carolina. The only one that would have any influence otherwise is the Attorney General.
Got it.
And I don't know why he would,
Right.
but we have to recognize that the Attorney General has final say.
And I would simply add, I think the ideas and the policies and the programs that we develop certainly could be helpful and help people in other parts of the country as well. So we're not opposed to that, but the fundamental purpose is to help the people of Western North Carolina.
Great. All right, I'm going to move us on along a little bit. We actually have several questions coming in that follow a certain theme into what the impact of this decision will be on various groups. And I think certainly the first group we all think of is what will be the impact on our patients. I know we've talked about that somewhat, but a specific question, or actually several that came in prior to the event as well as now, is whether services that may have been previously discontinued by some part of Mission, is there a chance those will come back under HCA? So what are your...
Yeah, so I'll start out. It's probably referring to labor and delivery.
It doesn't say that, but that's, right.
So I first want to highlight that the two decisions that we made to discontinue labor and delivery services, first at Angel and Franklin, that was largely an economic decision. And the losses that were incurred there were simply not sustainable for that community. And we had an odd circumstance where the other hospital, Harris Regional, even though it was a competitor hospital, had the ability to get paid more for the same cases. And so the way to improve the total amount of resources made available to that community was unfortunately to withdraw and allow Harris to receive the larger amount of money. It's not inconceivable that that could be revisited because the program was a high-quality program and it was a good program, but I wouldn't say that's likely, but we would have to remain and see what kind of efficiencies that HCA can bring and how that might be impacted. The other location was at Spruce Pine in Franklin. That was not an economic issue. Saving more money wouldn't have helped that program. That was a quality and safety issue that really related to the demographics and the fact that there were simply too few deliveries there, and those deliveries were spread across many different doctors,
Right.
so that the doctors on average only delivered a very, very few number of deliveries. So there's really no solution for that unless there's population growth. But of course, we will always look at opportunities to expand services, whether those are returning services that at one point didn't make sense or not. But no promises in that regard.
Okay. Another question that we've seen come up frequently is how costs will be impacted, how costs to patients for care and services might be impacted by this change. We may not know enough about that yet, but what are your...
I think it's a little hard to say at this point, but certainly in terms of direct cost to patients and their insurance, we don't envision any obvious differences, but that's one where I think it's a little hard to tell early on exactly how it compares to what Mission is.
I would just add, and this is something that most consumers, regular normal people, don't understand, because healthcare is so sort of complex and Byzantine, right? But we don't really determine what it is that we get paid, right? So 75% of our hospitalized patients are Medicare, Medicaid, and no pay. And Medicare tells us exactly what they're going to pay us, and then they tell us next year they're going to pay us less than last year. Medicaid, the same thing. And for the most part, because of the vagaries of our insurance market, with one very dominant payer, they basically tell us what they're going to pay us. So we don't really have control over our revenue. So when the question is what is the cost is going to go down because HCA's costs are lower.
Exactly.
I wouldn't expect any particular impact on the consumer's cost, at least not in any near term, because we don't have any control over that, and HCA is not going to have any control over that.
And to Dr. Ball's point earlier, HCA actually makes a little bit of money on Medicare patients, correct? So
yeah, and that's I can't emphasize enough, right? I believe in the future that everybody's going to pay like Medicare. That's just a personal belief, and we've always strived to be able to break even plus on Medicare, because once you get to the point where you can make money on Medicare, you're kind of invincible. As Dr. Ball pointed out, the average not-for-profit hospital loses 11 cents on the dollar on Medicare. We are much more efficient than the average, and we lose 4.5 cents. HCA is right around break even, makes so by them bringing that to us, that's a really important change.
Exactly. Beyond those things, we've also, Dr. Paulus, you spoke earlier about cancer care, about research and those kinds of things. Beyond those things we've already talked about, are there other impacts you anticipate that patients will see as a result of this change? I
guess one thing is probably worth mentioning is that while Mission has always had a fairly robust graduate medical education program with family practice residencies, other residencies coming on now, a surgical residency and psychiatry residencies. HCA is the largest provider of graduate medical education in the nation. And so while we have a lot of programs and we have a lot of ideas, they've also implemented these. So the opportunities for us to decide whether even more teaching programs and training of providers here could certainly be possible in that setting. We have the platform to build on top of that. They have the experience and have done that across the board, and I think those are also some very exciting opportunities.
That's great.
There's another great opportunity that that scale brings, or that HCA brings with its scale, and that they will have more than 180 hospitals when they have us. And they have a long track record of learning best practices from different hospitals, because each of those is an opportunity for experimentation. That is, what can we do better? And then they can apply that across the system. So we can help them in quality. They can help us in quality in areas that we can learn from.
And that is a very exciting opportunity for us.
And if I could flip back to John's comment about medical education, highlighting a couple of things as an add-on. We've had a terrific relationship with MAHEC, which is the Mountain Area Health Education Cooperative here in Western North Carolina, and they've been a tremendous partner. And there's lots of opportunities for them to benefit from this relationship as well. And later this week, I'm going to be going to Chapel Hill to UNC. We've had a terrific relationship for the most part with UNC. We're very involved in the creation of sort of a UNC West campus that includes our current efforts around the School of Public Health, the School of Pharmacy, the development of a School of Public Health here in Western North Carolina. And so I think there's opportunity for education that's really powerful. And HCA is not an academic entity, and it looks to partner with academic entities within each of its own local markets.
Great. So those relationships we already have
will be a benefit.
Serve them very well. So let's shift gears a little bit, again, looking at what this change may mean to various stakeholders in our community. We've gotten lots of questions about potential impact for our Mission Health staff, our team members. I realize a lot of those we may not have answers to yet, but I'll read some specific questions in a minute. But Dr. Paulus, I wonder if you want to speak generally to what we know about that.
Yeah, and that's an obvious question, and it's a very reasonable and thoughtful question. I don't have an answer that will fully satisfy, the curious person, and it's not because I have information I'm not willing to share. It's because we don't know the answer. Right. But I can tell you a couple of important principles. One of the things that we did with the board when we sat down in January and really said, for every time we've looked at this, and we've looked at it multiple times, we've always concluded that remaining independent was the right choice. And we could have remained independent. And we forecasted what the future was likely to be under the independent scenario, and then compared that to the partnering scenario. So the first thing I can say with 100% certainty is whatever job dislocations there are or aren't, they will be dramatically less than what they would have been had we continued on independently.
So having a partner
will dramatically reduce that. That's number one. Number two is people don't realize that the ebb and flow of jobs in healthcare and in other environments is always ongoing. So in the last 4 years, we've eliminated more than 500 jobs in Mission Health. Now, a large chunk of those found other jobs within Mission. Some people chose not to, et cetera, et cetera. And even while we were eliminating jobs, we always had job openings.
Right.
So just to be direct, I don't anticipate any significant or even really much of any impact on clinical roles. On the back office administrative overhead areas, and again, not because they're not great, they're terrific, not because they're not efficient, they're as efficient as they can be, but because of the enormous scale that HCA has, that's where the synergies or the potential dislocations are likely to occur. But, number one, any of that will be a lot less, as I said.
Right.
Number two, and this is really important, is that HCA is a very large company. They employ more than 220,000 people. They have more than 14,000 current job openings. And they have a large number of back office administrative staff, and the majority of those, or at least half, are positions that can work from home.
Right.
We also know that in that back office administrative area, turnover in all organizations, including ours, is high. On average, it's about 20% per year. So when I look at everything combined and I say there might be some disruption, but there are all these job openings open here, and let's just take a biller or a collector. If they're no longer needed to collect for Mission, that doesn't mean that they can't bill or collect for California or Ohio or Colorado or Florida and do that from their own home, right? In addition, because of the natural turnover, lots of jobs are created all the time. So I wish I could say that everything's going to be perfect and no one's going to ever lose their job, but that's not true of any organization, certainly not true of any healthcare organization. But when you look at the combination, I think it's going to be modest. And then lastly, these two gentlemen and the other board members, when I went to them and I said, I'm really concerned about any potential disruptions, and again, we don't know of that.
Right.
But how can we do our best to make sure that if someone is impacted, that we are as thoughtful and compassionate as we can possibly be, And our board approved a very, very large employee transition fund, so that not only the benefits that we provide to everybody today in the event of a transition, but those benefits will be enhanced if we get to that point.
Right. So if people are impacted, there will be additional resources
Yes, there
to help
will.
them. Okay.
And I think I might reiterate a point I made a little bit earlier, and that is with regard to the clinical staff, I know the concern is there job shifting or other changes. That would really have to do most fundamentally if staffing ratios were changed. And because their staffing ratios overall are so similar to ours, that's really not likely at all. And I know that's a major concern that people have, and that's worth repeating.
Thank you for that. I know this is, and again, I think a number of these questions may be more specific than we have answers to right now, but we're committed. Yeah, we're committed to asking them. So, do we know? Several questions have come up about. Do we know about HCA's pay and benefits and how they might differ from Mission's?
Yeah, again, I can provide not a specific answer, but I think a pretty good overall answer. It's another generic answer, which is what the letter of intent describes is that for all the employees that are transitioning to HCA, a couple of things will happen. They'll be moved over at effectively their current pay rate.
Okay.
Now, with benefits, there's never an exact match.
Right.
This thing's a little bit better, this thing's a little bit worse, this thing's a little bit better. What they've agreed to is that on average, things will be at least equivalent.
Okay.
So that doesn't mean that everybody's pet benefit will be carried over specifically, but I think that's the best that anybody could do is to say that, add this extra, take away this little thing to keep things fair to everyone. On average, everybody's going to be, the goal is everybody's identical when they transition over.
And again, those are things that, those details will become more clear as we move further through this process.
That's
correct?
right. And in general, but I can't say for every specific thing, in general, tenure and other factors will be carried over.
Okay.
And there'll be some transitioning of vacation that's not transitioned over will be paid out. Right?
Okay.
So nobody's going to have anything sort of, taken away from them.
Right.
You can't say everything's going to be identical because there's no such thing as identical. And we change stuff every year.
Right.
So,
exactly.
but I think it's very fair.
Okay. I do want to make sure we have time to move on to some other things, but there is one more question. Again, we may not know the answer to this. Well, there's lots more questions. One more question on team members, and that is, do we know if team members will need to reapply for their jobs? Is that something still to be determined?
We don't have any anticipation that anybody will be reapplying for jobs. I will say that everyone will go through the new hire process, which includes drug screening and questionnaire and all that kind of stuff. But there's no intent currently for any sort of reapplications.
Okay. All right. Thank you. So so that we've talked about patient impact. We've talked about team member impact. I think we've touched on this already, but I would like to invite Drs. Ball and Garrett to add in anything else, I think, on the impact to the wider community. We've talked a lot about the foundation that will be established, but beyond that, or even delving more into what the foundation will bring to us, what would you add?
Well, the two big impacts are the amounts of money and the change in programs and enhanced programs that the foundation will bring. The second impact is the tax money that the localities will come, both in sales tax as well as in property tax as well as in income tax. Those are two big things. For example, Asheville is looking at a budget deficit this year.
Right.
That budget deficit alone could be covered by the property tax and the sales taxes
Right.
that HCA would be paying. Now, that's not the way that Asheville should balance its budget.
Correct.
But nevertheless, that's a benefit
It's a
to the
benefit,
community.
right. Okay. Dr.
I think what I would add is another point regarding the region, and that has to do with the fact that while we have done extremely well looking at how we've worked with our affiliate hospitals since, say, 2010, and the strength of that system has improved, we also know that if there was bad financial performance across the entire system, that there really were no guarantees that any hospital really was going to remain here forever.
Right.
And if you look at other states, we've been remarkably fortunate. In adjoining states from us, when we look at the last 18 months, in some markets, there could have been 25 to 35 or 40% of small hospitals that were closing. And as part of this agreement, we've also stressed the importance of remaining a system. We've worked very hard at becoming a system, and so we want our system to remain intact as long as that is absolutely as is possible. And so we have also been able to include within that agreement assurances, much better than exist right now, that these other entities and regional hospitals will remain viable and active.
That's great, and actually that pertains to another question that we've had that we had submitted ahead of time about planned projects that we have going on. For instance, the Mission Hospital for Advanced Medicine here in Asheville, the new Angel Medical Center out in Franklin. So I think you addressed that just there, but any specific?
But to reiterate, HCA at this stage in the letter of intent has agreed to maintain and complete the new tower, the Hospital for Advanced Medicine, the Angel Medical Center, as well as behavioral health.
Okay. Great, thank you.
Yeah, I want to emphasize that last point.
Yes, please.
People don't really appreciate this, but HCA is the second largest provider of behavioral health services in America. People say, oh boy, for-profit, they're not going to take care of behavioral health. No, they do take care of behavioral health. And they have committed to continue our plans for a brand new behavioral health facility that's significantly larger than the one we have today.
Great. Thank you all very much. I think unless there is more to say on that, either community, patient, or employee impact, we'll shift a little bit now and go, we do still have some questions that have come in, but I'll also just remind our viewers that you're welcome to submit questions. We're going to get to as many as we can through this process. Hopefully we've answered a lot of your questions as we've gone along, but I will open that up, and one of the questions that came in while we were talking about the new foundation is Suzanne was asking if board members or executives will be among those to get positions with the new foundation. I don't know if you all want to address that.
We're in the process right now of deciding who will be the board. We've already decided what the purpose of the foundation is. As I said, that's to improve dramatically the health of the people and the communities of Western North Carolina. We've decided on a name, but which is always a sticky little thing, but nevertheless very important, and we'll be announcing that not shortly,
Excellent.
But when it's time to be able to announce that. It's likely that there will be some continuity of people on the board, because one of the things that the foundation will do is to assure that the promises that HCA makes in the definitive agreement are carried out.
Right.
The foundation becomes the legal entity by which we can hold HCA to its promises. So for that reason, there's a necessity that some of the people, current people on the board, but it will be a minority of the board of the foundation that will have come from the mission board.
Okay, and I do just want to reiterate for people who may not understand, our mission board members are completely volunteers. You all do not get paid for all this time.
I joke that every year our pay is doubled, and it's always the same, zero.
But I think that is an important point to clarify because people don't necessarily know that. Another kind of series of questions that we've gotten in has to do with how this change may impact physicians and providers. And Dr. Garrett, you spoke to that a bit about the partnerships with the medical schools and all that. But one specific question is, will we work to recruit new doctors to Highlands and other areas? So I think you addressed that a bit.
Good question. We have, although I think we're reassessing the needs in every place. And I think we're also open, and HCA is open, to both independent physicians and employed physicians. We have about a third of our physicians who are employed at Mission, and in HCA, a larger number of those physicians are independent, but when they have physicians in certain specialties they need to hire, they hire them. So they're open to both, and we really, I think, will just continue to do a needs assessment and see in each individual hospital in the region, as well as in Mission, how we think that's best going to play out.
And I would just add, it's important this isn't to pass the buck, right? That it's a national crisis recruiting physicians to rural areas, right? And it's really not a money issue, because we today often pay more for a rural area than we do in a if Asheville's urban,
right. Comparatively.
But the challenge is, it's not a money issue. It's an issue of where does the physician want to live.
Right.
It's an issue with the school systems. It's an issue with the infrastructure. It's an issue with how busy they can be and how complex of patients they can see. This is not to say one is bad and one is good. It's just a reality that getting physicians into rural areas is a problem. HCA will bring additional recruiting expertise, a broader reach, but I come back to that foundation again, because if we look at where some of the needs for social support and infrastructure are the greatest, they're often where the population is the least. And so I do believe that the combination of that foundation and the HCA's expertise with all of our existing team members can begin to make an impact, because once those social systems and sort of health infrastructures are better, we'll have a better chance of recruiting and retaining physicians to those areas, as well as doing what we've been doing, which is to move to more and more virtual care, more and more assisted care. That's the way that medicine's transforming.
And I think I would add there, another change that we've made in the last few years is looking at clinical guidelines, both in the hospital setting and in the outpatient setting. And part of taking the best possible care of patients is doing the right thing and doing it every single time. So that means if we have all our guidelines in place, and they pretty much are now, and we're developing new ones every week, basically no matter which hospital you go into, the care should be the same. And if you need a higher level of care, we'll put you in the right level of care that you need to be in. But we will have the same policies, the same guidelines, and the same assurances no matter which facility you're in.
That's great. Here's another quite specific question related to providers and physicians. Sasha had previously submitted a question asking if this move will improve appointment times for physicians under Mission Health. I think that speaks to the demand for those services, but anyone want to tackle that one?
I'll just say that appointment times and scheduling are the bane of healthcare's existence.
Yes.
And really, it's challenging for consumers and patients. We've done a number of things. We opened Mission My Care Nows at all of our locations, which are walk-in appointment availability. We have Mission Virtual Care, which is all online, and most of the time you don't even need to be seen by a physician. It's a $45 fee. It's pay as you go. But part of when I refer to administrative efficiencies, that does include the entire administrative process, from scheduling to appointment to insurance verification and billing and collections. So we do hope that some of the skills and experience and IT systems and infrastructure that HCA has will provide benefits.
Got it.
But I don't want to promise too much.
Right, I was going to say, we can't say that yet. Dr. Garrett, Dr. Ball, anything you'd add to that? So, okay. Again, we're going into a series of questions that we haven't necessarily covered. They're sort of individualized questions. So this is one from Stacy that came in earlier. It's my understanding that clinical research is centralized in Nashville. How will this affect our research department at Mission? Do we know that answer yet?
I'll partially answer it, and I'm going to say this with a grain of salt in it, because I don't think it's true that everything's centralized in Nashville. At the division level, which is what we would be, there's also a research infrastructure. I think we will get tremendous support from Nashville, especially in oncology, but not exclusively oncology. But I do not anticipate any significant changes. In fact, we just hired a new director of research, a physician who's terrific, and that was right during this transition, and we inquired as to the stability of that function, and thumbs up, good to go. So I don't anticipate a lot of change other than enhancement from Nashville in that area.
And I agree.
Okay, great, thank you. I see we're coming up on 7 o'clock. If you all can stick with us for just a few more minutes, and if our audience can, we do have just a few more questions. Sure. Is that all right if we continue on? I want to make sure we try to honor as many questions as we can. So this one came in a little earlier this evening. Uta is asking, was acquisition by an educational healthcare system such as Duke or UNC Healthcare considered? And if so, what steered the board toward HCA as opposed to more of an educational healthcare system?
We looked at a number of, we looked at a number of systems, including those in the state as well as outside the state, before winnowing down to HCA. But what what the educational systems could bring in efficiency was so much less than HCA could bring, and that was the one thing that we needed the most.
In that efficiency.
The efficiency, because of our payer mix, because our people are sicker, poor, and less insured.
And I would only add that, you know, we've had, for the most part, a terrific relationship with UNC. We have other relations with other academic centers, but UNC's been the larger one. And as I mentioned earlier, since HCA is not an academic, in some ways we get to retain those relationships that we have already without having to disrupt those, sort of choosing, you know, one academic center versus another. But Dr. Ball's point was spot on. When we look around the state, and I don't say this with any disparagement, we're the most efficient provider in the state. And so then the question is, if we need extra efficiency, where's it going to come from?
Right.
And that was crystal clear that from the HCA perspective, they brought that efficiency, and they brought some really interesting clinical things, but it doesn't cause us to have to disrupt our existing academic relationships.
Okay, great.
I would just add that we also have to look logistically to see how this is approved by the state and the Attorney General. And as we look through a lot of systems across the state, we see that with them we share a lot of markets, we share a lot of other things that would face a considerable scrutiny by the Attorney General, and could actually be a much more lengthy process. So one of the things that we're concerned about is saying, well, we know we need to make this move, we know we need to do what's best for us, and we really want to make the choice that we are pretty certain is going to happen. So we think that that's another reason we made the best choice.
Yeah, if you look at our market, we're touched by Duke Life Point to the west, UNC in Hendersonville, Carolina's Health System in Morganton. I'm not focusing on any one of those. I'm just describing, you know, specifically the point that John was making.
Right. Well, and to that point, Linda has asked, will Pardee also become part of HCA? Pardee, part of UNC Health System?
No, the Pardee is completely separate and independent.
Right.
Although I will say Mission Health Partners, which is our accountable care organization, our clinically integrated network, of which Pardee is a participant, we anticipate that going on as is.
So Mission Health Partners should
Mission
continue.
Health Partners is a very important entity. Pardee is a very important partner within Mission Health Partners. And the fact that there's a new owner doesn't have anything to do with their participation.
Great. Again, this is sort of I'll call this our grab bag of questions. We've got lots coming in. Again, I invite the audience, as long as you can stay with us, we'll continue on for a few more minutes, so we will try to get to your questions. So Kim is asking, how familiar is HCA with post-acute care, such as home health and hospice? Do we know the answer to that at this point?
Moderately familiar.
Okay.
HCA's had a very long history, and they've had times where they're doing, you know, some things versus not. I think they really saw significant value add in the degree to which we've integrated the whole continuum of care. Care Partners is a really important and valuable part of Mission Health, and they saw that as being a value add for them.
Okay.
So some of this will be new, some of it will not be new, but they really saw the whole package as being a very valuable thing. One of the ways that HCA operates is with a fair degree of divisional autonomy. They don't just sort of dictate from Nashville, you're going to do this, you're going to do this. They define targets and performance parameters, and then it's really within the divisional structure that's defined. And they do a lot of experimentation within their different divisions. It gives them a chance to explore new ways of caring for people, and they're very excited about the Care Partners part of our operation.
Excellent, great. Again, grab bag question. Barb is asking, will our EMR change? And we may want to explain what our EMR is and what that means. So,
Because this is a good story.
Oh, good. Let's hear it. Let's hear it.
Yeah. So the EMR will not change.
And the EMR
means an electronic medical or electronic health record. We use Cerner. In the overwhelming majority of our practices in all of our hospitals now. And HCA is very comfortable with that and has no plans in any near term that's remotely imaginable to make any change in that.
great.
And that's actually in the letter of intent.
Oh, okay, excellent. Shelley is asking if EMS service, particularly in Mitchell, Yancey, and Madison counties, will change, or do we expect that to change as a result of this?
Yeah, I've had a number of questions about this. I don't, I can't give a definitive answer in that I know for sure it's X, but I have no reason whatsoever to believe that it's going to change. We provide financial support to most of the EMS services, and that'll be a discussion that we have as part of integration and due diligence. That's also a possible area of focus, and I'm not in that role that a foundation might be interested in. So we don't know all the details, but on average, I see no reason why there'd be any significant changes. We think our EMS systems are working well. Mm-hmm. We've developed protocols and relationships and parameters, and folks may know we have paramedics that even during their downtimes go into people's homes to do home visits.
We call them caramedics.
Caramedics. We're very appreciative of our EMS colleagues, and while I can't swear on a Bible and give a promise, I just don't see that being something that gets changed.
Okay. Here's a question. I know you all have had these questions previously since this announcement was made, and it's really about HCA's history, so I'll let you all decide who wants to answer this. But Anne is asking, is it true that HCA was fined twice a considerable amount of money for Medicare fraud? So who would like to take that one?
One of the things the board looked at, because we're doing our due diligence, which we did before the decision, is the history of the organization. And HCA did, under previous management, have some very great difficulties. They really did have a epiphany, though, and their compliance program, that is compliance with law, compliance with regulation, is even better than ours now. They're a model for that. They've changed. They've got new management. They've continued to have the sense that they were founded, which is put the patient first, and they've righted the ship. And it's been a long while since they've righted the ship.
Right.
Yeah, that they were founded by two physicians, who really said, put the patient at the center, create an environment where you do the best possible care, and everything else will follow. Right. That sings to my heart.
Right.
And I would also add, relative, HCA did have a challenge, a significant challenge in the mid-90s after they were acquired by another entity. I would also note that there is no health system in America that hasn't paid a Medicare fraud fine. Why? Because the regulations are so Byzantine and so complex and so lacking in clarity that routinely we as health systems are audited and are challenged on this billing practice or that billing practice. We even have in our local region, to our south, an organization that paid one of the largest fines for physician fraud ever in America. I don't mean that to sort of say it wasn't an important thing. It is an important thing. But what Dr. Ball said was we looked very deeply. The very first time I went to HCA, I spent the majority of my time with their chief compliance and ethics officer. And I am willing to say that I believe they either are the most compliant company in the industry today, or they're pretty darn close to it.
Sounds like they've learned a lot of lessons from their prior experience.
As we all do.
Yeah, right. Sadly.
As we all should.
As we hope we do, right? Exactly.
Yeah,
exactly. Kind of to this point, David is asking if Mission Health's guiding principles will change, and that's more of an insider to Mission term, but I think it probably also speaks to mission and vision and values. Will those change?
I'm glad that question was asked, because I care a lot about those guiding principles. I don't really see them changing in any substantive way. We compared those guiding principles to HCA's principles. That's not to say, just like we created those several years ago and they didn't exist before, and we tweak things over time as we learn more and circumstances change. So I'd hate to ever have anything completely etched in stone, because then you can't grow, learn, and become better. But I don't think at the core, if you said, take away the individual words literally and said, do the fundamental principles change? They don't change.
Okay. Anything you all would add to that?
No, perfect.
Okay. I do want to start wrapping this up. I'll add that someone has made more of a comment than a question, that we have feedback that it would be helpful and insightful to have someone from HCA as part of a guest panel for the future. And let me add to the audience that we do plan some additional conversations like this via Facebook Live and other formats. So we don't have specific dates for those yet, but we'll be making sure that you all are all aware of that. Dr. Paulus or Dr. Ball or Garrett, I don't know if you all know if there's a possibility of HCA being a part of the panel, but certainly I think our audience is saying they would love to hear from them. So.
Yeah, I think it's a fair question. We can raise it. I will say, without ruling it out, that as a publicly traded company that's overseen by the Securities Exchange Commission and others, they run into many challenges with respect to public statements. Okay. That's why, on the one hand, you can find out anything you want, because whatever they say, they have to say it to everyone almost in the world simultaneously because of the potential impact on stock price and so forth. So having once been the CEO of a public company, I know how difficult that is, and how many lawyers you have surrounding you about what you can say and can't say. But I won't rule it out, and I will raise it with them.
Yeah, I think that'd be great. Thank you. We do have a question from Meredith asking if we could once again review the timeline just before we wrap up here. So Dr. Paulus, you want to take that one?
Yeah. And is this the wrap?
Yes.
Okay.
Yeah. If you'll review the timeline, and then we'll have just some closing comments.
Okay. So the timeline is we signed the letter of intent and announced that towards the end of March. We are in due diligence that began at the end of March. We looked that to be a 90 to 120 day period. So in a perfect world, which my staff says is not possible, and we would finish by the beginning of July. It will probably spill over into later July, maybe early August.
So that's the first phase.
And in parallel, we will be negotiating definitive agreements.
Okay.
What do definitive agreements mean? That means that we will have a signed deal, but not a letter of intent that's not binding, a signed deal between HCA Healthcare and Mission Health that consummates the transaction. Once that deal is signed, then and only then can the Attorney General review the deal.
So that has to be done before.
That has to be done before.
Okay.
But that is a signed deal that will either be approved or not approved, okay? So that then triggers off a 90-day review period, and the Attorney General will be looking at those three things that I mentioned: antitrust, market consolidation, there is none. Two is HCA paying a fair price? We have to determine the price, but for a variety of reasons, I'm very confident of that. And the third is, how is that money going to be used to benefit the community? Because it can't go to me. Sorry, guys, it can't go to you. It can't go to anybody other than the community. And the Attorney General has a very important role across all three of those things. So if we just said, let's say for argument's sake, we finished due diligence and had a signed definitive agreement July 1. Very aggressive, not likely to happen. Then we'd have July, August, September. At the end of September, we would then have the possibility of having a closing on October 1.
Okay.
A real closing where, okay, now we're part of HCA Healthcare, the money gets transferred to the foundation, everybody becomes employed by HCA, all of those things.
But you said that would be a very, very aggressive timeline.
That is the most optimistic possible, very unlikely.
Okay, great. All right, and I do want to give each of you all a chance just to make any closing comments, but before we do that, I want to remind our viewers that there is a website that you can go to at any time. It's called, the web address is missionhealthforward.org. You can stay up to date with the latest information about this timeline and this progress toward what we hope will be a closed deal within the next several months. You can also submit questions there, just as you can submit questions questions on this event page that you've already had questions submitted through. So missionhealthforward.org is your ongoing resource for information about this process. So with that said, I'll turn it over to whoever wants to go first with
I'll go first.
Yeah.
And I think I would say that as a clinician, as someone who's seen patients here for many years and now worked within our system and also worked nationally with gastroenterology, I've seen the threats we've seen here occur throughout the country. And I've seen the challenges that we face this year and the real likelihood that we would have to either reduce programs, reduce staff, curtail some services, and for people in our community who have worked so hard to create this entity, that was the last thing that we wanted to do. So to have the opportunity to create an agreement and join with a system who does so many things so well, which complement the things that we do well, so we can both help each other, is what we see, I think, as the absolute best possible opportunity for us.
Thank you. Yeah, Dr. Paul?
This is an incredibly important deal for the community in two big ways and a bunch of small ways. The two big ways are the care, the quality, the safety, the access, the services that people in Western North Carolina have come to expect will continue under HCA at Mission. Second, in addition to that, this huge foundation will be formed that will pour tens of millions of dollars into the community to actually improve health. So health care will continue and the improvement of health will be added.
Wonderful. Dr. Paulus?
Yeah, great comments. I'd just like to put a capstone on that point. I have been out meeting with community members almost every day. I was just in the last few days, I had a meeting with the SIBO group of business leaders last Friday, and then meeting with a large number of local clergy. Later this week, Monday morning, I had a meeting with many, if not most, of all of the not-for-profit healthcare system leaders, not-for-profit community organization leaders in Western North Carolina. And everyone starts out with questions and some concern and skepticism, and that is absolutely understandable and correct. But what I've seen is that when people actually learn what the facts are of this integration, this extraordinary opportunity that we have to take the best of what our teams have created for so many decades here in Western North Carolina. Mission Health just having been named one of the top 15 health systems in the United States for 6 out of the last 7 years. And bringing the expertise that HCA has in its scale and clinical capacity, in its informatics, and so much more. We have what we have today with the same people, the same name, the same organizations, the same sites, but better as a health system. And then we get for free, and it sounds too good to believe, we get for free through the sale this incredible foundation that I will tell you, even though you can't appreciate it today, that when people look back 30, 40, 50 years from today, they will say that the creation of that foundation did more for the health of Western North Carolina than anything that's ever happened. And people from around this nation and around this globe will come to Western North Carolina to see what can be done when you invest in those social services and other determinants beyond having a state-of-the-art health system. That's what we're committed to deliver, and that's what we believe will be coming. Thank you.
Thank you. Thank you all for joining us for this conversation tonight. Do remember to keep an eye on missionhealthforward.org for the latest updates. Also, keep an eye on the Mission Health Facebook page for announcements of upcoming further discussions of this sort. Thank you again, and have a good evening.